Dassault Systèmes has been a great partner in our effort to deliver modeling and simulation workflows to our patients, and excited to share with you today our efforts in redefining preoperative planning. I'm going to share with you our work in patient-specific 3D modeling, virtual surgery, and computational fluid dynamics. So I'm going to share with you some of our efforts through the lens of a recent patient we took care of, sort of highlighting some of the ways we're using modeling and simulation to impact real patients. So this patient is a 4-year-old with heterotaxy syndrome, right-sided polysplenia, who also has hypoplastic left heart syndrome, where there's one right ventricle that is able to send the blood to the body, and a very small and non-functional left ventricle. But also has a very important venous abnormality, has what we call interrupted inferior vena cava with azygous continuation. So all the blood flow from the lower body comes up the azygous vein near the spine. And so as a newborn, this patient underwent a stage 1 operation, or a Norwood, and then as an infant underwent the second of the 3-stage operation to get to the Fontan circulation, where we did a Glenn connection, connecting the superior vena cava to the pulmonary artery, and then leaving the azygous vein in place. And now this patient's 4 and ready for a Fontan operation. But the challenge is we know they have significant potential for hepatic venous flow maldistribution to the lungs. And so we made a 3D model of this patient's anatomy from their MRI. And you can see here, I have a pointer. You can see here in the blue, the SVC connects to the pulmonary arteries. And then on the right side of the screen, in teal, the azygous vein comes up and around the right pulmonary artery to the right atrium. And so the challenge here is which Fontan operation will give an adequate balance of blood flow, both the total blood flow to both lungs, and importantly in this patient, the hepatic venous blood flow to both lungs with low energy loss. And the operation that we would do if we had no modeling or simulation would be a lateral tunnel or an extracardiac Fontan. Another option would be hepatoazygous shunt, shown here. And really the challenge for this patient is the blood return from the liver has to distribute somewhat evenly to both lungs. Otherwise, if one lung gets very little or no blood flow from the liver, you'll develop abnormal blood vessels in that lung called pulmonary arteriovenous malformations, where the blood will go directly through the lung without picking up oxygen, and this is a progressive and fatal condition. So what we really have to do is get the operation right the first time. And so we've developed many workflows to use modeling and simulation in our patients, and it starts with a CT scan or an MRI, and then through a process called segmentation, we're able to create a digital 3D model. And then that 3D model can be used in several ways. It can be used for preoperative planning or intraoperative guidance, but it can also be used as a platform for advanced engineering work like virtual surgery or flow simulation. We use these models in the operating room at Boston Children's almost every single day. We have the access to the model through a web-based viewer from Materialize called the Mimics Viewer. We can pull it up on a screen in the OR. We have clever engineers who have reprogrammed the Nintendo Switch controller. For those of you with children, you'll recognize this. We actually have that in a sterile bag on the field. We can manipulate the model and use it for intraoperative guidance. But importantly, we're advancing our engineering approaches to develop real computational plans for the surgery. This is the workflow for virtual surgery, so we're able to take the 3-dimensional model and then plan a VSD patch or a baffle, or how to enlarge the pulmonary artery or the aorta. And as we heard yesterday, this is not only a geometric problem, but this is a really complicated biomechanics problem. And so in order to get this right, you have to understand how is the pulmonary artery or the aorta going to stretch, and how is the patch material going to stretch, and what's going to be the result when those are sewn together. And so what comes of this is a 3-dimensional shape. We're able to flatten that and then transfer that into the operating room. And so this is one example of virtual surgery. So this patient here we're considering for a Fontan, we can model the different Fontan options with a virtual surgery approach. Another option is to use this for intracardiac repair. So this is a patient with a complex ventricular septal defect So as a 3D model, we're looking inside the right ventricle in purple, and through that, we're able to see the left ventricle, and there's a large ventricular septal defect with a displaced aorta. So we have to create a VSD patch that both closes the VSD and baffles the left ventricle to the aorta. And so you can see we've been able to plan that patch in green. And then what we're able to do is to pull that patch out of the model. And of course, it'd be nice if they were always circular, flat patches. They never are. They're always complex 3D shapes. And so then using the the 3D Experience tool, we're able to then create the flat patch equivalent of that. And not only the geometric equivalent, but also then take into account the mechanical properties of the patch material to adjust the patch size. So when the patch is inflated under physiologic pressure, it'll achieve the normal size and shape that we need. We can dimension that patch, create markers for anatomical positioning, and then take that plan in the operating room. And we started this work long ago. A very brilliant Dassault engineer, we're talking about how to get these patch designs in the operating room, and he said, well, of course you're going to use the laser, which, as engineers and physicians, we didn't know what the laser meant, but as many of you know, a common tool in aerospace engineering. And so we actually have a laser system that we have in the operating room. We're able to project, we're able to upload from 3D Experience the patch design to the laser. The laser projects that patch down on the patch material. We trace it out, we cut it out with scissors, and sew it in. And we validated this process, and despite using soft and squishy patch materials, we're able to get less than 2% error between the patch design and the cutout patch on the field. Another example of a complex patient who has the heart shifted to the right instead of the left, with the left ventricle shown in orange, the right ventricle in purple, the aorta coming off the right ventricle. We're going to do a complex 1.5 ventricle repair in this child. They need to design a VSD patch that goes through the right ventricle to baffle the left ventricle to the aorta. And you can see here looking inside the left ventricle, we're able to design that patch and place it in this patient. And another area that we've really focused on in the last several years are patients with hypoplastic aortic arch and coarctation. This is a very common congenital heart defect with a wide variation in postoperative outcomes. So this is a 3D model of a normal aorta. And what we see is patients have really tubular hypoplasia of the aortic arch, and then an area of discrete narrowing past that last branch called the left subclavian artery. And how we repair this right now is we enlarge that entire aorta with a patch, and often we'll use pulmonary homograft, which is quite a stretchy anisotropic patch material. Some surgeons will use autologous pericardium, but there's wide variation in how those patches are initially cut and then trimmed in the operating room to achieve the result. And of course, this is done on newborn children who are 5, 6, and 7 pounds, and so the quarter gives you a sense for how small these patches are. The challenge is that there's a lot of variability in the arch geometry currently after the repair. This is a study we did not to highlight the variability, but to really understand how these aortas grow over time after patch material is added. And what we found is there's significant geometric variability both at the time the aorta is reconstructed and as the children grow. I'm quite sad to report that y-axis is the z-score, which for the non-clinicians in the room is a standard of deviation. So you have many standards of deviation both above and below the target range. So this is in dire need of a better approach. And so some of the challenges of this is that when the surgeon's reconstructing the aorta, they're doing it with the aorta at zero pressure, right? So that there's no blood in it. You're sewing the patch in place, but all you care about is what's the size and the shape of that aorta when it's pressurized. And so this is a complex geometric problem, and it's a complex biomechanics problem to understand all those things. Additionally, we're taking a two-dimensional flat patch, and we're really asking it to curve 9 different ways. And so for the surgeon to estimate all those things in their head obviously is too much. So what we really need is a standardized patient-specific workflow for these patch designs. So we've been developing that similar to the other workflows that you've seen to achieve a patch size that's going to work, and then obviously take that into the OR and project it with the laser. And so we've done this retrospectively, and Ashley and Jang from Dassault, I think, are in the room, have played a really important role in helping us develop this technology, and we're on the verge of doing our in vitro validation and start to use this clinically. This is all done on the 3D Experience platform. Similar to that, we've tackled pulmonary artery reconstruction. This is another real challenge in our field. So patients who get patch augmentation of a small pulmonary artery have up to 40% reintervention rate on that pulmonary artery, either catheter-based or surgical-based reintervention. So another real opportunity to improve what we do. So we've been able to generate a patch planning workflow for pulmonary arteries, and we're in the process of preclinical validation of that workflow. We've created a specific pulmonary artery model that has the right mechanical properties of a normal pulmonary artery, and then we've been able to design patches, sew those patches in place, and then validate the whole workflow by putting the pulmonary arteries in a micro CT scanner, inflating them to physiologic pressure, and then doing a validation analysis of the size. So if you look here for both a neonatal pulmonary artery and an infant pulmonary artery size, what you can see here are the shapes of the two different patches, and then on the bottom are the diameter profiles, with the black, of course, being the stenosis before it was resolved, the target shown in the dashed line, and then the colors highlight the different patch materials. So we've been able to work out all the details of the biomechanics and the geometry and the suture take-up to really get a very predictable pulmonary artery size. So we're in the process of moving that towards clinical implementation. But I think one of the challenges we face as we develop these more advanced workflows is what's the right approach to take before you introduce this into the clinical space. And so we've been very fortunate to be part of the enrichment project, which we're going to hear more about later today, which is a terrific collaboration between Dassault and the FDA and various academic and industry partners. And we recently published our work on creating a platform or a framework for in silico clinical trials. We're fortunate to work with the same terrific group at the FDA, Brent and Kenny and Prass, to now take some of those fundamentals, including a credibility assessment platform, and now applying that to this preclinical validation of patient-specific surgery workflows. So we're in the process of finalizing a manuscript in collaboration with the FDA that's going to outline both our preclinical validation work and how the credibility assessment that's used in modeling and simulation for devices is now tailored to this preclinical assessment. Similarly, for our patients with computational fluid dynamics, we're taking that same approach and taking the credibility assessment that the FDA has outlined and then adapting that for how you apply computational fluid dynamics in a clinical setting, and about to publish that also. So two very important works as we advance this towards advance the regulatory science towards, software that's going to be FDA approved. I'm going to talk a little bit about our computational fluid dynamics. This is really where we started in this effort in the very beginning. And so now we're able to take these patient-specific models, do virtual surgery, and adapt patient-specific boundary conditions from the MRI and the cath, and do CFD to analyze different surgical approaches. And what we really feel strongly about is we need to model these circulations under multiple physiologic conditions for robustness analysis and understand how this is going to work for real life. And so we model these patients under anesthesia, which is where they get their studies, under normal resting physiology, postprandial state, and an exercise state. And this has really been important to understand how this is going to work in real life. So getting back to our Fontan patient, we were able to do CFD to understand, okay, for the operation that we would have done, how well was that hepatic venous flow going to be distributed? And you can see here, under normal resting conditions, we're going to have 90% of the hepatic venous return to the right lung and 10% to the left lung, and certainly that's not going to work. And so we looked at then, what about a hepatoazygous shunt, which is often a good option. In this patient, it's a little bit better. So you can see here now 81% to the right lung and 19 to the left lung, but you can see it looks like there's almost parallel paths of how the azygous flow comes up into the pulmonary arteries and the superior vena cava flow comes down. So what we really needed to do as engineers is to create some mixing at that ASGUS SVC junction. So we're able to design a patch to do that. We dimensioned that patch, flattened that patch, and then we redid the simulation and said, okay, what if we do this with a patch reconstruction of that area? And you can see now we've induced really nice mixing, and for normal resting physiology, have 63% of blood flow to the right lung from the liver, 37% to the left. Normal in you and I is about 60% to the right and 40% to the left because our right lung's a little bit bigger. So this is really a nice result. And this child underwent that operation, and then we did an MRI to validate the results and showed that the hepatic venous flow distribution was 70% where we had predicted 63. The total flow distribution was 51% to the right. We had predicted 57. So really nice congruence with the CFD. And we published a recent series looking at MRI validation of these patients. We did computational flow dynamics, showed 51% average predicted flow to the right lung, plus or minus 5%, and the post-op MRI showed 49%, plus or minus 8.5%. So really nice congruence, and I think it goes to our really meticulous approach to designing patient-specific boundary conditions based on their physiology. Another patient that we did recently where we looked at what the surgeon had actually planned to do in a Fontan completion, which is shown there in the red box, which unfortunately would have resulted in 100% of the hepatic venous return going to the left lung in this complex patient. And after multiple CFD analysis, we were able to get it really nicely balanced at 52 and 48%. We've also done CFD in patients who already have these arterial venous malformations. This is a 21-year-old patient. You can see in a normal resting condition had 100% of hepatic venous return to his right lung. And after virtual surgery and CFD, we're able to get now 66% of the hepatic venous return to the right lung, or excuse me, to the left lung, and we've shown a dose response to this. And so when we do these Fontan revisions, we really try to get the majority of the hepatic venous return to that affected lung to heal those AVMs quickly. So what we found is patients with systemic venous abnormalities really need CFD analysis prior to Fontan completion. In our series, 71% of patients had less than 15% of predicted hepatic venous return to one lung had they had an operation with no CFD, and obviously that puts them at substantial risk for reintervention. And their final surgical plan had 36% to one lung with a range of 23 to 49%. So we're really able to tackle this and make important recommendations for these patients. Another area we've focused on recently are Fontan patients as they grow, and the recommendation or the practice pattern for the entire field is you get a Fontan and then that's your last operation unless you need a heart transplant. And what we found is that that's maybe not the right approach. And so we looked at patients to understand how their flow changes over time as they grow. And so the age that you get your Fontan, you actually have twice as much venous return from your upper body because it's bigger. And then as you age, your lower body grows in proportion. And so at the age of 8, you actually have equal venous return. And by the time you're a teenager, you actually have twice as much venous return from your lower body as you do from your upper body. And when we looked at these patients as they grew, what we're finding is the energy loss across the Fontan conduit goes up dramatically as you get older, in part because the flow goes up and in part because your distribution changes and completely flips. And so this is creating a whole new paradigm for how we're thinking about these Fontan patients as they age. And we're able to use CFD to model how to upsize these Fontan conduits for patients who need it. And you can upsize the Fontan conduit to a point to decrease the energy loss. And then if you oversize it, you'll actually increase the energy loss because you get swirling and inefficient flow. This is a study that was released earlier this year out of the Washington, D.C. group, which shows early development of liver cirrhosis in patients with Fontans, particularly those with small Fontan conduits. And this is the CFD results from a patient that matched that cohort that came to Boston Children's, who was really doing quite poorly, a 16-year-old who had too small of a Fontan conduit. We did CFD. We found that she was having dramatic rise in her IVC pressure with any exercise. And if we upsized her Fontan conduit, we were able to reduce the power loss by a factor of 3. She actually was really debilitated, couldn't even go to school because how ill she was. And so we did her Fontan conduit revision. She finished high school. She's now in college and doing very well. And I think there's a huge opportunity here. So central message is 3D modeling and simulation is really essential in planning and conducting complex reconstructions. Surgical planning by experience alone is inadequate. Single ventricle patients with systemic venous abnormalities or AVMs really need CFD. And Fontan conduits are maybe not adequate size for everybody. And CFD can help us understand who to upsize. So just a couple words. Welcome to come, Steve. A couple words about our team. And so this is led by myself and Pete Hammer, who's a PhD mechanical engineer. And we've really put together a team of professional engineers to do this, which has allowed us to scale what we're doing. And where we started, very humble beginnings, doing CFD for a few patients, has now really expanded to a huge percentage of the patients we do at Boston Children's. This year, we're going to create over 400 patient-specific 3D models, accounting for almost 40% of our patients who have surgery. We're expanding this work to other centers throughout the U.S., and a key piece of this has been the financial aspects and how to support these engineering teams and this technology. So we've been billing for this effort for about a year and a half, and that has really opened the door for other centers to start to take on this work at another level. So there's about 9 centers in the U.S. who are starting to hire engineers, and we're teaching how to bill for these services. And on a national level, we've submitted CPT Level 3 codes for this to achieve durable billing for these processes. It's quite expensive, as you can all imagine. I think this is going to be a super important aspect to make this care available to everybody. I've left one important part of our work out and left it for our next speaker. We have a huge effort in 3D modeling of valves, which we've really pushed over the last few years and have done about 170 aortic valves and mitral and tricuspid valves. And I'm going to leave our next speaker to share some of our AV valve modeling work with a very unique perspective.